Hey there, welcome back to EMS Abounds. This is going to be one of the AEMT chapters on my YouTube channel, chapter 26, Hematologic Orders. You may be viewing this because you're in one of my classes and this is how you're getting this chapter, or you may be looking for some Con Ed. That's great. You may be in somebody else's program and you're looking for a little bit of help with this chapter. Whatever reason, I'm glad you're here. Welcome. And away we go. So hematology, study of blood and blood forming organs and tissues. So, you know, National Registry loves definitions. I might want to know that. It also has to do with how the red blood cells, white blood cells, and platelets work or don't work. So platelets, right? Coagulation, clotting factors. Now, let's review blood itself, right? Plasma. Over half of it is of the blood is made of plasma, and 92% of plasma is water. One of the last chapters I just did on burns, I talked about electrical burns, and electricity takes a path of least resistance, and it wants to go to ground. And I said it will follow the bloodstream. This is why 92% of plasma, which makes up more than half of blood, is water. So that makes sense. We have some formed elements. These are actual like particles within the bloodstream. Red blood cells, white blood cells, and platelets. So what do? Red blood cells, right, have hemoglobin on them. They carry oxygen. Hemoglobin binds to oxygen. There are other things that these cells do, but this is the big one that concerns us. White blood cells fight infection. Platelets for clotting. Now, how many liters of blood does the average adult have? 5. If you look at that 5'9" to 6 foot tall adult, right? You're talking roughly 5. One of the books, I think it's an EMT book, has a picture of this, and it shows an infant with a 12-ounce can of soda in front of them. It shows an adult male with 5 1-liter bottles. Okay. Infants have roughly 12 ounces of blood. Let's talk about scalp injuries for a minute, shall we? Scalp wounds always bleed. There's lots of capillaries. Well, if I have a scalp wound and I bleed a lot from it versus the infant with the scalp injury, which one of us gets shocky first, right? So keep in mind volume. 5 liters for that. For me, I'm 5'11", 5 liters. Right? 12 ounces, which is what, 355 milliliters in an infant. Now, in our body, our liver and our spleen do a lot of filtration, okay? The bone marrow does also, and it filters, the liver and spleen filters a lot of junk, but red blood cell or blood cells as a whole are one of them. So as they get old and or damaged, they get eliminated through these 3 areas. Now, erythropoietin is a hormone that stimulates the bone marrow to produce red blood cells. Erythropoietin is released from the kidneys. So on the screen it says liver. The liver secretes it when you're a fetus, but after that the kidneys take over. There's a ton of other reasons though that the liver will screw up your red blood cell count. Macrocytosis, which is an unusually large red blood cell and it doesn't carry oxygen, is one of them. And the other is that as the liver fails, we develop portal hypertension. So high blood pressure within that portal vein system, and that causes hypersplenism or maybe hypersplenism, and it causes the spleen to over filter our red blood cells. So think about kidney failure and liver failure. Both of these patients are going to be chronically anemic, right? Low red blood cell count because they're not creating enough of it, all right? Now, within the plasma, we're going to have proteins as well. Albumin is a protein. Our clotting factors are proteins. Our antibodies are proteins. We also carry our electrolytes, sodium, potassium, calcium, magnesium. It carries the nutrients, our vitamins, our fats, our proteins, okay? The medications that we take, the hormones that control our body, and any other sort of substance that we happen to stuff into our body gets transported in the plasma. Now, you don't have to, if you're in my class, you don't have to study this diagram. I like people to understand that, the kidney is involved in this, as is the liver. The oxygen levels start to drop in the tissues, we release erythropoietin, which stimulates the bone marrow to increase production, which then allows better movement of oxygenation and better tissue oxygen occurs, okay? So red blood cells are flattened discs. And by the way, the capillaries in our body are exactly 1 blood cell in diameter. It allows for maximum surface area for gas exchange, but they're flattened discs. Disc is round. A frisbee is a disc, right? So a red blood cell is the shape of a frisbee. Perfect surface area. Their lifespan is roughly 120 days. We're going to talk about sickle cell anemia, where that is significantly less. Those sickle-shaped cells, have a significantly lower lifespan, and the marrow can't keep up, and those folks are chronically anemic. Hematocrit and hemoglobin. So these are measurements that can be done through the laboratory. It can be done finger stick, bedside testing, right? Point of care testing. There are units out there that ambulance services could buy that would tell us blood gases and H&Hs, hemoglobin, hematocrit, but they're expensive, and that's why ambulance services won't, because historically they're too cheap. But anyways, hemoglobin directly tells us the oxygen carrying capacity of the blood, okay? And hematocrit is what percentage of that blood volume is formed elements. You do not need to know what normal H and H's are. I mean, like hemoglobin for an adult, 14 to 18 for a male, 12 to 16 for a female, 47 to 57, 42 to 52. It depends on some of that is dependent on the laboratory and what testing they use. So just understand that low is anemic. And when somebody, let's say you're doing a transfer and they say, the patient's anemic, what are they? What are your values, okay? White blood cells are also produced in bone marrow. Now, red blood cells are produced in long bones, in the marrow of long bones. Red marrow in long bones produces red blood cells. Irregular bones have yellow marrow. They produce white blood cells. So different types of cells within the white blood cells, within those counts, do different things. We don't need to know this. White blood cells fight infection. So if our white count is high, right, 5,000 to 10,000 is a fairly typical number. If somebody's got a white count of 13, they're fighting an infection someplace. They're creating more white blood cells to go fight that infection. Platelets. Platelet counts are God, was it 150,000 to 400,000? It's a pretty wide gap. But the platelets get sticky and stick to each other and stick to that injured tissue, creating that platelet plug, which then becomes the clot. Okay, so clotting cascades and like 14 different clotting factors, you don't have to worry about that. But understanding platelets are the beginning point of this. Platelets go out, they stick to the injured tissue, they stick to each other, then that platelet plug is the basis for that clot. Hemostasis. Now there's homeostasis, which is a balance. Hemostasis is that process of stopping the bleeding, or of the bleeding having stopped. Okay, we have 3 phases following an injury. So the vessels that are injured will constrict to slow down the flow of blood, which allows those platelets to start to plug up and allows the clotting cascade to occur. If that vessel's wide open and blowing blood like a garden hose, those platelets are never going to stick. So we've got to slow that bleeding down. The body does it intrinsically by constricting, vasoconstricting to that vessel. We, by providing direct pressure, will help slow that flow down also. Now, do not study the next 3 slides, okay? You do not need to know all of these things. But I like to include them because I like people to see that there are some very kind of mild things that we don't think about that really do have an effect on clotting. Alfalfa, okay? Aspirin, we know aspirin because we give aspirin to our cardiac patients, right? Who we think are having an MI or could be having an MI, because that helps platelets function. Eliquis, this is a big one that people are going home on. It's a big anticoagulant, okay? Plavix is the other big anticoagulant. There's kind of 3 that we see on a regular basis. Warfarin, which is also known as Coumadin, Plavix, and Eliquis. So these folks are generally the ones who are at high risk for clots. They have a PE, they're at high risk for PEs, MIs, and strokes. Okay? Garlic. People take garlic supplements as a very good form of helping prevent events as you get older. Okay, but garlic, it's just garlic. Well, in the concentration that people take garlic supplements, if you take a garlic supplement, you're going to have surgery. They'll tell you to stop taking it up to a week early, so that way you'll clot after the surgery. Ginger is another one. Ginkgo biloba, you hear that? I mean, all the time. Any NSAID, non-steroidal anti-inflammatories. These are your ibuprofens, your naproxens, your Motrins, which is an ibuprofen. Okay, Xarelto is another one we're seeing quite a bit of. Vitamins can inhibit platelets or improve their ability to work. Okay. Blood grouping, ABO and RH. So we have blood types A, blood types B, AB, or O's. Type O is the only one that can receive type O blood. As far as universal donors, universal recipients, in my mind, this is like cool trivia. We're not giving blood in the field. Know that A positive has to have A positive. B negative has to have B negative. The O, see, I don't even remember it off the top of my head. I've blanked out completely. In babies, newborns, there is a risk of this hemolytic disease. So like dad was an Rh positive and mom was an Rh negative. Okay, so they can do in that case God almighty, I am blanking out today, but they can fix this to make sure that the baby has the blood type of mom, so that the baby does not have this reaction. Complaints, the exact nature of the problem. So sickle cell, these folks are anemic, have chronic anemia, but they're also at risk for clumping, as we'll see in a few minutes from some slides. Clumping basically is clotting or acts like a clot. Warfarin, there are any of these injectable or ingestible, kind of what I think of as heavy duty blood thinners, your bleeding problems. You're more risk to bleed, less ability to clot. My trauma patients, I'm worried about that, okay? Leukemia, low counts, low white counts. They can't make white cells to fight infection. And if they have excessive platelets, they're at a risk for throwing clots. One of the things that we might see are what we call petechiae. It looks kind of like a rash. So, you know, I would think of this guy as being, you know, probably one of my anticoagulant patients. You know, one of the patients who's taking these blood thinners. You can also get petechiae as a sign of local damage. You could have pressure building up. Strangulation patients, right? You shut off the blood flow through the jugular veins, and you have the carotids pumping blood into the head. You have blood leaking out of the capillaries because of the back pressure building up, and you can develop petechiae from that. Most of the petechiae in strangulation you're not going to see, but you might, if you flip down the eyelids, you may very well see it inside the eyelids fairly quickly. So look for bruising. You know, when you have one of these anticoagulated or hard to coagulate people, right? We're going to look for bruising, signs of bruising. We're going to treat them appropriately with oxygenation, fluid replacement as needed, analgesia. Signs and symptoms of any of these disorders: get tachycardic, right? You're bleeding somewhere, you can't clot, or you throw a clot. It makes sense. You become tachycardic. You're having trouble with perfusion. You're trying to bring in more oxygen or get rid of more waste, so tachypnea. Your body senses all of this going on and says, "Oh, I can't breathe. I need more oxygen. I can't breathe." Right? Fatigue, malaise, weakness. If you are anemic, especially, you're not carrying as much hemoglobin around, you're not carrying as much oxygen, even though your sats are 100%, you're not carrying enough, it makes sense that you get worn out quickly. A little pallor, swollen, tender lymph nodes. So that's up in your armpits and in your neck. Fever and blood in your urine. Petechiae, right? Looks like that rash. Purpura, sorry. Bruising, right? They're smaller bruises though, but petechiae are pinpoint, and these are 3, 4, 5 millimeters in size. Unusual bruising or bleeding, you know, there's really nothing to explain it. Itching, belly pain, joint pain, or swelling. Syncope, passing out. Jaundice, liver. Okay, severe night sweats. Now, assessing and managing these things: baseline vitals, monitoring as appropriate. Get a good list of the patient's meds. I hate this when people, you know, like if I do an intercept, you got a med list? No, they got it at the hospital. Which hospital? Are we going to the one that has their med list? What about what we want to know right now? Okay, so get a good med list at the house. if the patient's critical and you don't have time to write stuff down and they don't have it written down, then throw them in a Walmart bag and bring them with you so I can start looking through them. Okay. We need to know what their meds are. Blood transfusions, and I hear this from a lot of EMTs and AEMTs are like, why do I need to know this? We don't give blood. No, but good chance you're going to be on a transfer truck someday and the medic's going to be doing blood. Okay. You may have a vented patient in the back of the ambulance getting blood, and it's you and the medic. You've got a third person driving. So the medic might be kind of at that critical mass where he's almost over his head and he's worried about vent settings and he's got pumps running. And if you can watch out for this, you could save that person's life, right? You may go to an outpatient surgical center for a patient who's got became short of breath, okay? And you're like, okay, great. So they've called 911 and you're taking them to the ER and you notice it looks like he's having maybe an allergic reaction. Ooh, maybe there's pain at the site, chest pain, back pain, restless thing. Fever and chills is a big one with transfusion reactions, right? Tachycardias, things that come along with all of this. The guy's heart rate's starting to climb. Well, there's a lot of things that can cause that. Take a temperature on this dude, right? Renal failure, kind of a late sign and not something we're probably going to see or be able to diagnose in the back of the ambulance, but right. Let's talk about some red cells specifically. Anemia, low hematocrit, low hemoglobin, low red blood cell count. It could be that we're not making enough red cells. It could be we're losing them, like we're bleeding, or we're losing them because they're being destroyed. All right. But regardless, when we start to have anemia, we start to have a decreased ability to transport oxygen. Now remember, the CO2 gets transported back generally in the plasma, but some of it will be carried on the hemoglobin also. Anemia signs and symptoms. You're worn out. You don't have any energy, right? Every time you get up and you go do something, you get tired. You may be a little short of breath with it. Okay, you get a little pale. Maybe just sitting there, you're pale. You do something exertionally, you get short of breath because you're not carrying enough oxygen. So your brain says, hey, I need more oxygen. I can't breathe. I'm having trouble breathing. Now, severe cases. Hopefully by the time it gets to this, they've already gone to the ER. Signs of heart failure. Now, we see this in the ERs a lot. People show up and they're just, I don't know, I just don't feel good. And I'm kind of worn out. And, you know, I walked to the mailbox today and I get a little short of breath, which is not usual. So I just don't feel good. I want to be checked out. And sure enough, they're anemic. And then they try to figure out why. So if you go into the ER and you're anemic, they're going to check holes for blood, right? So holes for blood. Have you been throwing up? Have you had diarrhea? They're going to stick a finger into your rectum and they're going to smear a little bit of stool on this little Hemocult card and put a couple of drops of developer on it. If it turns black, dark blue or black, then you're bleeding internally. You know, you've got a GI bleed of some sort. Right? So they look for what causes it. Sickle cells. A sickle cell, if you look at this right here, it looks kind of like a boomerang, right? It looks like a sickle, a scythe that you cut grass with, right? That, you know, death stands on the side of the road waiting for you, right? With his scythe. It's got a sickle on it, okay? These do not flow smoothly like these. So they clump together and basically form a clot. It's not truly, it's a clump, but it acts like a clot. It blocks blood flow and you can have dead tissue downstream from that. So where does that clump form? Lungs, heart, brain. Looks like a stroke, acts like a stroke. We need to treat it like a stroke, okay? You know, with the whole regular When did it start? Last known normal signs and symptoms of a stroke. It may be caused by sickle cell. Okay. Who has sickle cell? So it's genetic, and it's very common in those of African descent, right? But also we do see it in some Middle Eastern, Caribbean, South and Central Americans. Their blood cells, so this says 10 to 20 days. I've seen in writing anywhere from 28 to 45 days for sickle cell red blood cells to live. But regardless, normal cells, 120 days. It's a lot less. With hope, they can tell us that they have sickle cell. They can tell us they're having a crisis. I'm having a sickle cell crisis. I'm having chest pain. I have sickle cell. This is the way my sickle cell crises occur. All right, I am going to still treat that dude like chest pain, right? It is chest pain. It is clumping in probably one of the coronary arteries. It could be in his lungs though, right? So I'm still going to treat him I'm going to treat him no differently than I would anybody else with those symptoms. They are prone to clumping together and causing these vaso-occlusive crises in the capillaries. So that's the difference. They tend to clump in the capillaries as opposed to blocking large vessels. Leukemia, large numbers of abnormal white blood cells. I think I did. I made a mistake earlier when I said not enough. I apologize. But so large numbers of abnormal, and because they're abnormal, they don't do a very good job of what they're supposed to do, and they crowd everything else out of the way. We get easy bruising. We get some bone pain. Our spleen filters damaged and abnormal white blood cells. You can have some left upper quadrant pain. It could get bad enough where it actually, the spleen could rupture. Swollen lymph nodes up in the armpits and in the neck. Repeated infections and fatigue. Lymphomas. So a cancer of the lymphocytes can be Hodgkin's or non-Hodgkin's. Survival rates for lymphoma is pretty good if caught early and treated aggressively. Multiple, and this is not something, by the way, leukemia and lymphoma, we're not going to be diagnosing in the field, by the way. This is more just background for the whole chapter. Multiple myelomas, cancers of cells in the bone marrow. So what's the bone marrow do, right? It makes red blood cells and white blood cells. So multiple myeloma, cancers in the marrow are going to have issues with white blood cell counts and anemia. But also it can cause damage in the bone itself, and that the bone material can actually break. It gets weakened, and what we call a pathological fracture, where you turn sideways and your femur snaps. Platelets themselves, low numbers of platelets, thrombocytopenia. You have trouble clotting. Okay, this is not uncommon in things with leukemias and other marrow problems. Thrombocytosis, increased platelets, and these folks tend to have problems with bleeding and clotting, as in too much clotting. Hemophilia, inherited. There's a ton of different types of hemophilias, and a lot of them actually skip generations, which is kind of weird. But so different clotting factors, and again, I could be wrong, but I think there's something like either 14 or I think it's 14 clotting factors. So they tend to have excessive bleeding whenever they do bleed. So a lot of these females, it's discovered when they start having their periods. They have abnormal bleeding. It's excessive bleeding. Their gums bleed easily, right? Think about going to the dentist and they ask you all kinds of questions about your gums, right? Bruising, nosebleeds, these pinpoint rashes that we talked about. They nick they're self-shaving and it just freaking bleeds nonstop. And they can have bleeding GI tract or urinary tract. So treatment is nothing we're going to do, but the treatment is replacement of that clotting factor. DVTs, so the deep vein thrombosis. So big veins deep into typically the backs of your legs are where we see it, because the blood flow distally to the back of your legs slows down from extended periods of sitting, for example, and you get these clots that start to form, which can break loose, end up in your lungs, and we end up with having PEs. These folks do end up on anticoagulants. DIC, disseminated intravascular coagulation, is an out-of-control cascade of events. A lot of times we see it in trauma patients who get cold, they get too much fluid, and they don't get enough oxygenation, and so their clotting system goes haywire. And they send out all of their clotting factors, which form all these little clots everywhere. And then the body goes, oh shit, sorry about that, and sends out all of its clot busters and breaks down all of those clots everywhere, including the ones we're trying to form to save our lives. So then you get excessive bleeding and excessive bruising. You get oozing of blood out of places that shouldn't have blood oozing. It can happen though, trauma, we see it, like I said. We also see it in sepsis patients. Now surgery, think about it, surgery is a traumatic event. You could also see it with blood transfusions. So just a little bit of a summary. Hematology is the study of the blood and those organs. We have plasma and formed elements. Plasma is the transport. The formed elements are those proteins and antibodies and blood cells, okay? Our red blood cells carry oxygen and carbon dioxide. A little bit of it will also be transported in the plasma. Any decrease in red blood cells leads to tissue hypoxia, and it doesn't matter whether it's because we're losing it from bleeding or we're not making enough. It leads to hypoxia. Sickle cell, we get the clumping and that capillary or microvascular occlusions, and antigens on that red blood cell give us the basis for blood typing. Infections result in an increasing production of white blood cells, and each type of blood cell has a very specific function. The hemostatic process, how do I control my bleeding? I vasospasm locally. I send some platelets to the area to clump together, and then I start the clotting cascade. Get a list of meds for every patient, please. DVTs, right? So high risk for DVTs. Recent travel, recent extended periods in a chair, right? Chair bound, bed bound. And where can those clots break off, right? PEs, we think of that all the time. So just got back from Seattle, flew in from Seattle last night. My legs were hurting me on the airplane. I figured I was just cramping up, but it got a little worse overnight. I had trouble sleeping, and now I have chest pain. They had a DVT, they've thrown a clot, they have a PE now. Out of control clotting, DIC. All right, so that is our chapter 26 of the AEMT book. As always, if you got questions, you can shoot me an email, emsabounds@gmail, or text me, etc. And I will look forward to seeing you at the next chapter.